Now, classic patient, heart failure with preserved ejection fraction, and here we really see a classic Cheyne-Stokes respiration, high HI, typically low PCO2. And this is an example how ASV does theoretically, and if you look carefully in practice, can work. It really stabilizes ventilation. So ideally, when you have a decrescendo, crescendo in tidal volume, the inspiratory pressure support increases, so anti-cyclic, and if it works, the algorithm has to apply less and less inspiratory pressure support. We observed this also over time, looking over 3 months. After a while, when you read the machine readout, the inspiratory pressure support usually goes down over time. The last patient, this is a 70-year-old heart failure patient with preserved ejection fraction. In the polygraphy ambulatory sleep disorder breathing test, and also clear severe central sleep apnea. But this patient was clinically decompensated. So here the first advice is not to start right away with the treatment, but start with the heart failure treatment first. And 6 weeks after recompensation of heart failure, we called the patient back to the sleep lab, and there was a slight decrease of the severity, and also the proportion of obstructive events increased. And my point is, when we look at the obstructive apnea, we see it's a clear obstructive apnea, zero flow, but there is effort in chest and abdomen. But if you look here at the ventilation phase, it's the crescendo, decrescendo, and it looks like a Cheyne-Stokes respiration superimposed on obstructive sleep apnea. And this is the classic patient where we can reduce the obstructive part, but actually we cannot change the central part, or even the proportion of central parts increases when we apply CPAP therapy. There is a time component. When we apply CPAP over time and keep reducing obstructive sleep apnea, the regulation of ventilation adjusts to the new situation, and usually the central apneas go down a little bit over time. So it was more effective 4 weeks later, but there was still a residual HI of 24. That's why we put the patient finally on ASV, which was a full suppression of apneas and hypopneas. So the prevalence of treatment emergent central sleep apnea differs significantly between heart failure patients and non-heart failure patients. So it's rare in cardiac, I switched it. it's the wrong way. It's rare in non-cardiac patients. So here in this study, we excluded patients with an abnormal BNP, and we had a very low prevalence of this phenomenon. So the prevalence was only 1.6%. And the Bad Oeynhausen group did the same thing in heart failure patients with manifest heart failure, NYHA class 2, 3. They had 18% of treatment emergent sleep apnea. This phenomenon, in my opinion, was first described by Doug Bradley. Is he still here? I've seen him. So this is a nice comparison of the pattern of obstructive sleep apnea in a patient without evident heart disease. So the sudden increase of tidal volume with the first breath, and here in a heart failure patient with also obstructive sleep apnea, the superimposed Cheyne-Stokes respiration. And when you see this in the diagnostic PCG, the likelihood that you apply CPAP and end up with central sleep apnea is very high. For adaptive servo-ventilation, I see the most important target population in the future are the patients, in my opinion, with preserved ejection fraction, either with treatment-emergent CSA or with central sleep apnea from the beginning. And we made a retrospective comparison how ASV can affect sleep quality in these patients. So the green ones are the treatment-emergent ones, so first PSG obstructive sleep apnea, and the blue ones CSA from the beginning. So in both groups, there is a significant AHI reduction and also significant reduction of sleep fragmentation arousal index, but it was similar between groups. The differences begin here. So the gain in sleep time and the gain in sleep efficiency was obviously higher in those who started with obstructive sleep apnea. And so with sleep efficiency, we have a clear significant difference, a 10% gain in sleep efficiency, which is huge in the TEXA group, TE CSA group, and no major change in the CSA group. And these are the data of the sleep profile. We saw significant improvements in both groups, so increase in slow wave sleep N3 and in REM sleep. But the improvement of sleep quality was significantly greater with respect to reduction of N1 and an increase of REM sleep in those who had obstructive sleep apnea in the beginning. So treatment emergent CSA in heart failure with preserved ejection fraction is probably the most common indication for ASV, and the ASV effects on sleep quality are greater in heart failure patients with preserved ejection fraction with TE CSA compared to CSA. So this is the most common target population, and I think we can do better in these patients. Good. And just simple advice how we proceed with our ASV indication. As sleep physicians, we have to adjust that we need echocardiography before we start ASV. And the rules are relatively simple. When the ejection fraction is reduced and we have central sleep apnea, treatment is treatment of heart failure. In some exemptions with excessive symptoms, we might try other forms of positive airway pressure or something else. When we have obstructive sleep apnea, we can do our treatment decision as we did before, and the same is the case when the ejection fraction is above 45. So thank you very much for your attention.